Thank you. Well, thanks for the very kind introduction. And Jim, thanks for being allowed into as a late arrival to the agenda. Much appreciated. Just to check, can you see my screen? Can you see the presentation?
Yes.
Perfect. Excellent. So I'll dive into it right away. And as I said, dialing in from Europe, Vienna, Austria. Thanks for being part of that very interesting meeting. I talk about how we treat dysphagia, which is swallowing disorders, and what's the health economic impact or the health economic consequence of it is we reduce lengths of stay predominantly in the critical care, which we focus on. So the device we're using is Phagenesis, and obviously, as it fits into the topic of today, it's a neurostimulation device. As this is also an investor stack, so we are a commercial stage company. We look forward to raise yet another round in the second half of this year. As we are commercial stage, it is really to scale our European and US commercialization. As we expect FDA approval this summer, we have CE mark in Europe already, and we try to address a market with a lot of potential. So there's quite a significant TAM behind it. And probably to set the scene, what's the market we are operating in is, let me quickly comment on or give you the context on the critical care capacity as a scarce resource. So obviously everybody is probably painfully aware of that topic as critical care as a scarce resource, because it was one of the main reasons why we had to work during COVID. Our masks, had vaccinations, were going through lockdowns. It was all to protect these critical resources as there weren't enough capacity. And hopefully now, there's why I believe that after COVID, this has self-regulated itself. That problem is less pronounced. The problem though is still up and out there because now after COVID, a lot of critical care staff, nurses have quit their job due to poor working conditions. They're burned out, many reasons. But the consequence clearly is that critical care beds can't be adequately staffed anymore. You see that in Europe, but also I've heard it from many sources in the United States as well. So this remains an issue, and there's no short-term fix, even now after COVID, because it's very difficult to build up that staff capacity again with all these people actually, with all these employees leaving their jobs. Why does length of stay matter in this context? So obviously for the patients, reducing lengths of stay means they can reduce the risk of complications, but also very important, get home earlier. Why is it for the healthcare system so important in the setup to reduce lengths of stay in the critical care? Because it frees up beds, and it saves obviously dollars if you get a patient out of the critical care faster by the patient recovering quicker. So what's the important part? Why are we playing a role here? What's our impact? Well, as I mentioned before, we treat dysphagia, and as a consequence, we can reduce lengths of stay in the critical care, because dysphagia, which is patient can't swallow and can't manage their own secretions, is associated with increased lengths of stay, specifically longer duration of intubation and tracheotomy for mechanical ventilated patients, risks of readmissions, and is independent predictor of mortality. So all the bad stuff, basically. And we have shown that with our Phagenesis neurostimulation, we can treat dysphagia. And that's, I think, the paradigm change. It's the first time that effectively dysphagia and the consequences of it can be treated in critical care, because most other treatments of dysphagia are rather happening in rehab because it's very cumbersome to treat patients on dysphagia. It's a training done by speech and language pathologists, which might take weeks or months for patients to recover. And typically you need patients to be involved in that procedure, which is typically not the status of patients in a critical care. Typical patients in critical care are not compliant with any kind of training or recovery or rehab therapies or strategies, with the exception to Phagenesis. So we can actually apply our therapy in this kind of environment and can successfully treat patients very quickly. And yeah, this is, again, it's an investor deck, so it's a little bit also already showing what we have accomplished. So we have a lot of clinical data behind it, 25 years of clinical research. We have already several published data. It's actually more than 17 studies by now, including a lot of RCTs. As I said, we have CE mark in Europe. We are considered an FDA breakthrough device, and we expect de novo approval in 2022. For the experts in the group, you will immediately understand de novo means. So there hasn't been any predicate. It's the first time that such a product is being offered. There's nothing yet available in the US market or elsewhere. And we have proven through our data that we can save dollars, that we can free up critical care capacity. And there's an interesting upside in the United States, which we might be very grateful about, which is the NTAP, the New Technology Add-on Payment as an additional reimbursement, by the way. But that's more on the health economic case. We own the space, as I mentioned, we're the first of its kind, and we have a strong IP portfolio. And while I mentioned that we are a European company based in Manchester, United Kingdom, I am based in Austria, but the company is based in the UK. We already have a very strong executive team built in the United States, as obviously this is still the most important market for us. And this might be oversimplification. I apologize already. But for those who probably already aware of the concept of dysphagia, it's important clarification. And so I apologize again for my oversimplification eventually. Dysphagia, for those who know it, is typically associated with oral intake optimization. So, you know, at a certain stage, it's really like that. A patient who can't swallow can't eat properly, so they probably have to eat thickened food, or you know, this diet has to be carefully managed. In the critical care, the consequence of dysphagia is even more difficult or even more pronounced because it's not only about our oral intake optimization. If you can't swallow, it's something much more pragmatic or basic, is these patients can't even manage their own secretions. And the consequence of not being able to manage their own secretion is that this will actually, as they can't swallow, secretions will aspirate through the airway. And that, of course, causes, if not managed, aspiration pneumonia as infectious material enters into the airway and into the lungs. So, and you know, what I try to show with that slide is, if this isn't managed, if swallowing isn't reestablished in the critical care, the only thing you can do is frequent suctioning. So that's a little bit the comparison to a clogged river, where if all the efforts are fighting the water with buckets, which is analogy of just frequent suctioning, and you don't remove the clog, in other words, the river can freely again flow. It actually will flood across its boundaries, will actually overflow its banks, and the issue isn't resolved. And same here, if you just do frequent suctioning, the problem doesn't go away. The patient still can't swallow, and you know, of course, if you can treat that swallowing issue, if you can make the patient swallow again, retrain the swallowing, as we do it directly in the ICU within 3 days, you can remove this issue, and hence the patient has an accelerated discharge in front of him or her, which means that the patient can be decannulated, can be weaned of the or intubation, and all the protection mechanisms in place because of that issue of swallowing disorders. Probably for this group, most important is, as I know that there are really neuro experts in the audience, is how does this work? Probably to give you a little bit of a background, what the basic of this is what we call the neurological swallowing loop. It's not on the picture, but to just explain it. So when a food bolus touches the pharynx, that's kind of the signal, the afferent signal to the cortex, to then time and coordinate the swallowing approach, which then gives a signal to the brainstem, to the medulla, where the central palatal generator is being based, which then actually triggers the muscles to close off the airway, to keep it simple, and process the food into the esophagus. That's what I call the neurological swallowing loop. And if this neurological swallowing loop is interrupted somewhere, that could be centrally, as I said, for example, in the cortex, through a stroke, through any kind of brain injury. It could also be peripherally at the pharynx, so that there is a desensitization at the level of the pharynx, and the patient actually doesn't feel the food bolus to come to start with, which might happen just to the pure presence of the breathing tube, you know, an intubation or even a tracheostomy. And because of this desensitization, the patient also will not trigger the swallowing appropriately, which then could be a patient after sepsis, could be a patient after COVID, could be any kind of patients who actually experience a long-term ventilation. Long-term ventilation means more than 48 hours, so actually not that long. Or it could be a combination of essential deficit, a stroke, plus actually the requirement to be ventilated. So actually the peripheral issue. There could even be kind of both be involved. So whenever that's interrupted, we can make a difference, because what we do is we put our catheter, which is a simple, actually it looks like a feeding tube, but embedded into the feeding tube, we have electrodes. We put it through the nose, and then the electrodes touching the pharynx, and actually the tip of the catheter going into the stomach, because we could feed the patient at the same time, which of course is critical for patients who can't swallow. But the important key element is that electrodes touch the pharynx, and that we can create with this neurostimulation what we call a super bolus. So we trigger the system by having an extreme sensory input into the system, and by that sensory input, the whole neoplastic recovery has been triggered. And that could be, as I said, increasing sensitivity at the pharynx. It could be really a central reorganization, which is pretty pronounced. We have shown in some of the research that in case of essential deficit, actually contralateral side will take over, which I think is a very exciting neoplastic response. And that's an effect which can be treated in about 3 days, which is the interesting thing. Also, what's important in our device, by the way, that catheter is connected to the base station, as you see it in the picture here, which is the stimulator box, kept it very simple. But what is important in our therapy, this is a temporary therapy. We put the catheter in place, just through the nose, touching the pharynx with the catheter tip into the stomach, just for 3 days, because we retrain the brain in 3 days. There's no implant, there's no surgery, and as I mentioned it briefly before, there's no patient involvement required. So it's really, you can do it with a patient, kind of even a RAS2 for those experts amongst you. So really, while the patient is still quite sedated, we can already work on the patient, with the patient, to retrain at swallowing. And we have by now about more than 3,000 patients treated, nearly 1,000 under research conditions, so well documented, and we have 0 serious adverse events. So this is a very safe device, as you can imagine, because what we do isn't in any way or form dangerous to the patient. So we have a very positive effect with actually nearly no risk for the patient. And then just for you to get a little bit of a feeling, where this has been used, I mentioned it in tracheotomized patients, but also patients which have been intubated. I probably don't go too much into detail here. What I want you to take away from the slide is the pronounced length of stay reduction. So what we have shown in our studies, if patients actually, once they're weaned from the ventilation, so they actually can breathe autonomously, and now what's preventing clinicians to remove the trach tube, if now Phagenesis has been used to retrain the brain in 3 days, there's a really pronounced length of stay reduction possible for these patients, because instead of now this very cumbersome and painful process to train and retrain swallowing in a way I've quickly described to you before, we can get this done in 3 days. And hence, of course, a pronounced length of stay reduction with all the positive health economic benefit. I just mentioned it here in the second arm. If a patient is not tracheotomized, so it's not a surgical breathing tube if you want, but still orally intubated, and then an extubation attempt has been made again after the patient is off the ventilator, and really what's inducing that extubation risk, meaning that there's a high risk the patient, once the breathing tube is removed, actually might have to be re-intubated again because of dysphagia, because there is no safe airway. As soon as the breathing tube is removed, the patient starts aspirating, as I tried to explain to you before. And if that's not treated well, not managed well, as particular to our therapy, Phagenesis, this is the symbol of our company here, then again, this is increasing lengths of stay and has a high risk actually that the patient needs tracheotomy in the end. I just want to make one thing very clear, because I know, again, there's experts in this call. There's really cool technologies out there like lung pacer, also kind of a neurostimulation. You might have heard about it. This is a treatment, and there are other treatments similar to that, which really reduces the duration of ventilation. Really, this is a therapy which can actually accelerate that patients can breathe autonomously quicker, which is great, but it's not something we are doing. We actually come after that, because we can be really relevant once patients are off the vent, and now the problem for the patient is they can't swallow, hence breathing tubes cannot be removed. And that's not a limiting factor for further recovery. We're also discharged from the ICU.
Okay, couple more minutes. Reinhard?
Is any questions, or shall I just, is timing okay?
No, I'm just giving you the 2-minute warning.
2-minute warning, perfect. That's helpful. Only a few slides left. So what I want to take away is a strong health economic case behind it. So basically, we have calculated for a US ICU or also LTAC setups where these patients typically are. There's a pronounced potential net saving, because obviously getting these patients out of these setups faster is a pronounced effect. But also important with case scarce capacity is that we get more patients through the system, that actually ICUs or LTACs can take more patients because we can free up beds faster. I talked about the setup in the ICU, critical care most of the time. This is just to establish that dysphagia can also appear in patients like stroke who actually haven't been ventilated, and where really the predominant issue is the stroke. So this has been very successful applied in these patients. I just focused my presentation on the critical care space, but also persistent dysphagia. So many patients fall out of the system after probably weeks or months of not successfully treating dysphagia, and still have the trachanal or severe dysphagia in place once they're in a nursing home. So even there, we have shown that we can make an impact. Huge opportunity. This is more economic parameters. This is just to show you the breadth of stimulation, breadth of evidence we have behind it. So, really nice publications, including Lancet publications. And only this summer, or only until this summer, we have new additional publications planned. Take-home message: we improve outcomes in the critical care by reducing risk of extubation failure. Hope I could explain it to a little bit. Accelerate deconvolution, reducing complication. That allows us to decrease cost of care, freeing up beds. And probably another important take-home message: this is the only therapy of dysphagia which can successfully, effectively be applied in the critical care setup. We retrain the brain in 3 days. There's nothing comparable existing out there. So with that, thank you very much for your interest and attention. I'm looking forward to any questions.
Okay, thank you very much, Reinhard.